Alright, in this video we're going to be testing the hip joint, starting with the active range of motion as always, and then we're going to follow up with passive and then resisted. So we're basically talking about acetabular-femoral joint. One of the things that we have to be considering that the client won't be able to do extension just like the shoulder joint. However, in this case, they're not going to be able to come to the edge of the table and the extension. So hip testing is a little bit more complicated than most others. We're going to have to ask the client to turn around, like flip multiple times during active passive range of motion testing. So just so you know, in certain times that I will do some adjustments. And the most important one is we're trying to isolate the hip joint. Anytime client does move the lower chain, pelvis and lower back will also want to activate and move with it. So in that case, that's why in certain cases, I'm going to be stabilizing the certain pelvis area, like anterior superior iliac spine and posterior superior iliac spine. So let's start with the abduction. So this leg, please, I would like you to do an abduction for me. In this case, I'm going to point right here, stabilize. That way, when the client does, we try to aim for a pure abduction of the AF joint. Because if I don't do that, let's see what happens. Let's do abduction. You will see that the entire pelvis is rotating, lumbar spine is rotating that direction. We don't want that because this is a compromised test now. That's why you have to have a very firm hand, push it down, and the second you start feeling tension under your palm, stop the test because now the pure abduction of the AF is done. Now the rest of the chain is kicking in, so that's when your test is finished. You know that much. For the adduction of the AF, when the client goes to adduction, they're going to hit the other leg. That's why I'm going to passively move the leg, the other leg. You can relax, perfect. And I would like you to continue with this leg and into adduction. Go for it. Perfect, and then center. Now, one correction we have to make, that's why hip is a bit of a tricky one. Again, as I said, I need to stabilize here. So in this case, I'm going to lift this leg up with one hand and stabilize it with the other hand. Now I'm asking the client to do an adduction, so go away from me. And you're not really looking for a big motion because you will feel it very much after 20-30 degrees. Right away the pelvis will kick in. So don't expect the hip to go a full adduction. It's a very limited motion. After that, I'm going to basically ask my client to bring your knee towards your chest, and that will be the flexion as far as it goes. Okay. Now in this case, we're looking at tissue stretch from the posterior or tissue approximation from the anterior. Depends on the patient. So passive range of motion, we'll mention that one more time. So in a lot of cases, you have to make sure that the client's range of motion is, it could be limited due to many different reasons. So keep that in mind. Again, let's do flexion one more time. Knee all the way to the chest. Now, bent knee is very important because if the knee is not bent, then you're actually adding a lot of hamstring tightness to it and it will be misleading. So knee bend is an important portion of the hip flexion test. And hip flexion test actually can go more than 100 degrees very easily. Now, supine face-up portion of the test is basically done. We could add medial and lateral rotation of the test by simply bringing the leg into 90 degrees of flexion, and I can ask the patient to please rotate your foot towards me, and that will be medial rotation of the thigh, and then rotate it away from me. That will be the lateral rotation of the thigh. However, this is a modified version of this test. There's a better version. That's why I would prefer to ask the client to turn over, face down, please. Go ahead, flip. And this way there is a much easier and more accurate version of medial and lateral rotation. Also, I'm gonna have to ask her to move anyway because I still have to do the extension. Now at this position, we have to realize something. Now the testing leg, the one that we were testing, is this one now, not this one anymore. A very common mistake that my students make, that they stay in this area and then they start doing the other leg. So there's a whole different assessment basically. So I'm going to move to the other side now. So I was always saying, class, follow the leg, and then a quick adjustment here. So bend the leg and ask the client, can you please kick the foot towards the ceiling? Now, you can relax. Now, as I will post it, you can relax. As I will post it, extension of the hip is actually roughly 15 degrees. So do it again for me, please. This is way more than 15 degrees. So we're looking at a lot of lumbar involvement, a lot of pelvis rotation involvement. So we don't want that. That's why, again, we have to really do a good job on stabilizing. Stabilizing on the posterior, superior relaxed spine, bend the leg. We're asking the client to slowly move towards the ceiling, and that's all we need, because the second I start feeling the tension, it's over for extension of the acetabular-femoral joint. So we're gonna look at one more time on how small this motion is actually. Go for it, and done. Less than that, a little bit more, that's it. This is all we're looking for hip extension. So try not to exaggerate, like, okay, go all the way as hard as you can, as much as you can to the ceiling, please. So this is nowhere close to accurate hip extension. This is way more than what we need. And this is the one that I'm talking about with external rotation, internal rotation. Now we have a really neutral hip here. And then now I'm going to ask the patient, after I stabilize the back here with both hands, either way, whatever works for you, one hand also works. I would like you to rotate your foot towards me, please. And that is internal rotation of the hip, and rotate away from me, please. And that is external rotation of the hip. Now, why am I stabilizing? If we can get from this angle, when the patient does the external rotation, the entire lower torso is basically lifting up. That already tells me that this exam is already over. This is way more than an external rotation of the thigh. Now we are looking at rotation of the lumbar spine. So that's why we have to do a good stabilization and push down. Once the client is doing the second, again, you feel the tension, it's over. So that's all the external rotation of the thigh she has. Rest, now we're looking at more rotation. Same idea with the internal rotation. The second she hits, and then I'm having stabilization here. The second I start to feel the tension, it's over. In most cases, most people have more internal rotation or more external rotation than the comparison, the force couple. So it's very normal. That's why you need to know your degrees a little bit more. And then we'll conclude our AROM. So make sure now to ask the client to turn. Let's go turn around again, please. And this time now I can stay here, and I'll proceed for the bilateral testing and continue with the abduction and adduction, the whole thing, and replicate what we just did on this leg. But don't forget to move it around back and forth, because this is one of those things that common mistake is staying in the same area, testing both legs in a different sequence. And that's it for AROM of the hip. We're gonna continue with the passive range of motion of the hip. All right, now we're going to continue our hip assessment with passive range of motion. In this case, as we always say, like, this is where I'm supposed to do all the motions and the client is supposed to relax as much as possible. Which is, when it comes to hip range of motion testing, is particularly tricky. A lot of people are not really good with relaxing, so it might take a little bit longer than usual. So keep that in mind. Now, we're going to try to keep the same sequence that we did for the active range of motion. So we will do abduction, adduction, and then flexion first as an anterior, like, supine level, and then we'll have to turn the client. So let's proceed that. Now, if you remember, there were some adjustments and stabilizations that I had to do, so keep that in mind and try to pay close attention to where I'm stabilizing, because those are important details to find out. Now, in this case, we're taking the leg and stabilizing, okay, and slowly moving into abduction, and we will basically have a tissue stretch on this. And stabilizing the opposite side is very important, because if I don't and continue, then we're gonna definitely have a rotation component involved, so definitely push. And the second you start feeling that tension, abduction is over. Now, in this case, I can actually ask the client to please bend your knee on the left side and hold it from underneath, please. Now, this gives me freedom to actually do a passive range of motion of the adduction of the AF. Again, I need to stabilize the same side this time. Remember, on the opposite side when I'm doing abduction, same side when I'm doing adduction. Very common mistake. I've seen some of my students actually try to stabilize the opposite side, which gets very, very awkward. So do not make that mistake, please. Same side, And remember, it's not a lot of adduction. So the second we're actually feeling the tension, adduction is really over. Again, tissue stretch, and you can relax now. Now in this case, we're looking at flexion, bend knee, all the way, passive overpressure. Now in most cases, again, tissue approximation or tissue stretch, both are really acceptable and feels. More tissue stretch, more tissue approximation than tissue stretch really. And that will conclude the supine portion, and I'm going to ask my patient to turn around. And don't forget, we have to follow the leg. So I'm going to actually follow the leg and stick with the right side that we were testing in the first place. Okay. Now, in this case, extension was the next one we did. Now, remember, even as an active component, extension was only 15 degrees, so it's very limited. So I'm going to get my hands under it, and realistically, I'm already done a portion of the extension of the hip by simply putting my hand under the knee. I need to make sure that my hand is on the same side of the PSIS, posterior superior iliac spine. And the second I start lifting it, it's over. You can actually start feeling right away that PSIS wants to move. The second PSIS wants to move, it's over. Extension is very limited. Again, you're looking at tissue stretch for the end feel. And in this case, for the passive range of motion, for the external and internal rotation, okay? Now we are going to do an internal rotation and make sure that, again, stabilizing the opposite side, because if I keep going, this will rise. But if you notice, client has a very good internal rotation. If anything, it is actually hypermobile. So in this case, let's remind ourselves that when it comes to hypermobility, we do not do passive overpressure. So we are not really doing anything on a passive overpressure level. So I'm going to reach to max and go beyond, and then no passive overpressure. If your client is restricted or you are basically on the within normal limit, don't forget to do passive overpressure, because now we would have a tissue stretch. And we're moving to the external rotation. And basically we have a hypermobile internal rotator and limited external rotator. You can see that hip is moving right away, thoracic spine and lumbar spine is getting activated. So make sure that you do your stabilization, go for it, and right here, basically external rotation is finished. When I do passive overpressure, we are looking at tissue stretch. This is a good example of abnormal end feel tissue stretch, which is in one of the videos that you will already be seen by now on abnormal end feel when I describe it. So this is a good example as a patient in real time, hypermobile versus tissue stretch, abnormal end feel. And that will basically conclude the one side of the hip, and then I will ask my client to turn around again. And then now I can stay here because now I will proceed with the left side. But at one point, unfortunately, again, I will ask my client to turn around and follow the leg and go that way and finish the 6 motion of the passive range of motion of the hip. Flexion, extension, abduction, adduction, and internal external rotation. Pretty much just like the shoulder, we have to do the same thing for the hip, and that will conclude the passive range of motion of the testing. All right, we're going to be doing resisted range of motion of the hip joint in this portion of the video. We already done our active and passive. So as I always do, I will try to stick with the order that we did with the AROM and PROM. In the AROM and PROM, we did abduction, adduction, flexion, extension, and internal and external rotation. So I'm going to try to keep the same order. Now, we always have to remember, resistant range of motion needs to be done on the open pack position. So when it comes to hip, it is actually 30 degrees of abduction, 30 degrees of flexion, and slight lateral rotation. Now, I don't necessarily expect people to be super accurate. So usually in my class, I point out that little bit flexion, a little bit abduction, and slight lateral rotation. And the client has to hold the leg, the thigh, in this position at all times. So the sooner and quicker and the good follow you do this, the faster and more accurate the exam will be. Otherwise, if you take too long, then the client will start getting tired, and now we have a compromised result. Also, I would like to bend the knee a little bit, because eventually I'm going to use it as a lever, just like I did with the shoulder with internal external rotation. Same thing will have to happen with internal external rotation. So keep right here, and we'll proceed with the testing. Abduction is on the side. I'm going to push from here. She will go to abduction. I'm going to push the client into adduction and hold. 5, 4, 3, 2, 1. Perfect. Now I'm going to push from inside. 5, 4, 3, 2, 1. Now I'll stop quickly and point out something. Make sure that you're still following up the ASIS here on the pelvis. If the client, like this right now, it happened, if you haven't noticed, when I push, don't let me move you, hold. If the client is really sticking the ASIS up this way, that they're activating other muscles, then make sure that you correct that. So sometimes you might have to again stabilize certain places while they're holding and then push this way. So I'm going to stabilize the ASIS on the other side. Don't move, you hold. 5, 4, 3, 2, 1, and relax. Now, it might actually just be enough to point it out and correct it without actually stabilizing. It's a bit of a subjective choice, depends on the patient. Now we're going to proceed with the flexion. I'm going to push from the top here. Remember, this is a bit of an oblique angle because of the slight lateral rotation. So don't push in the center here, then it will be flexion and adduction kind of confusing. So give it an oblique angle push and hold. 5, 4, 3, 2, 1. Excellent. And now we have done the flexion. Right away, follow up with the extension, please, from the bottom. Trying to push her up again, oblique angle. Don't let me move you. 5, 4, 3, 2, 1. Great. Now this is again the tricky part, just like the shoulder, because we will use the leg as a lever. Now I'm going to test the internal rotation. Now don't forget, internal rotation is this way. So I need to push the client into external rotation so she can activate the internal rotators. So in this case, I'm pushing from here. This is the stabilizer. This is not really pushing or pulling anything, just gonna be here. And I'm gonna push from here. Don't remove you. 5, 4, 3, 2, 1. Excellent. Make sure you stay with the open pack position as much as possible. Now I'm going to push from here and trying to put the client into internal rotation and hold. 5, 4, 3, 2, 1. To give you a visual presentation, I'm holding like this and I'm trying to turn this way, or holding like this, trying to turn it this way. So one more time for external rotation. Okay, I'm going to put her into external rotation, checking for the internal rotation. You can see, like, when I actually reduce my strength, so hold, go for it, go, 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 go. She's turning internal rotation. That's why it's called resistant range of motion. You need to dictate the strength. One more time. 5, 4, 3, 2, 1. And same idea here. 5, 4, 3, 2, 1. So as you notice, there is no reason to ask the client to turn back and forth. Open pack position can be done in supine, all 6 motions. And then now you replicate that on the other side by moving on the other side. And that will conclude your range of motion testing, finishing with the resistant range of motion testing of the hip.